Services Overview and Scrutiny meeting. It's now 7 p.m. and I would like to start the meeting. I would like to draw your attention to the evacuation procedures which can be found in the agenda under the information for members of the public and councillors section. I would like to remind you that under the Overview and Scrutiny procedure rules as set out in the Constitution, this meeting shall have a maximum duration of 2.5 hours. Therefore, if at 9:30 p.m. there are items remaining, the agenda item under consideration will be concluded within 10 minutes, followed by a vote, and items not yet considered may be deferred to a future meeting. I would like to remind everyone present that this meeting is being live streamed and recorded for publication on the Council's website. Apologies for absence. I've received apologies from Councillor Aliki and Councillor Hooper as the Cabinet Member for Health and Wellbeing. Are there any other apologies? No, thank you. Item 2 is the minutes. I move that the minutes of the meeting held on the 31st July 2025, as outlined in the agenda, are approved as a correct record. Are there any comments on the accuracy of the minutes? Okay. The minutes are approved. Item 3, declarations of interest. Does anyone have any declarations of interest to make? No? Okay. Item 4, unplanned scrutiny items and members' rights of reference. I've not been notified of any unplanned scrutiny items or members' rights of reference. Okay. Good evening. I'd firstly like to welcome Ruby as our new Director of Public Health. This is her first meeting here, so welcome, and we look forward to working with you. I would also like to welcome Councillor Day as the new Vice Chair of the committee. Our first item this evening, item 5, is the CQC inspection report on the adult social care. This was discussed last night at full council in Councillor Hooper's motion. The inspection was back in May and we received a good rating. Tonight we're looking at how we got that score, how we can maintain and improve. And so I turn over to Robert Percy to present the report, please.
Thank you, Chair. Committee members that were here will remember in April I came and did a long presentation about the impending inspection assessment at that time and what the CQC were going to go through, how they're going to go through it, all the information returns we had to make, all the people they would want to see, which wasn't just council staff in adult and social care, it was in adult health and social care, it was staff across the council, it was our providers, it was our key partners, it was communities, and they actually spoke with service users as well in receipt of our services, and that plays quite heavily in how they then form their judgments. That presentation was at Scrutiny in April, and then we had the on-site phase in May. I'd just like to start by just saying thank you. In response to Councillor Hooper's motion last night, I very much appreciated, on behalf of my colleagues, the comments were made from all sides of the chamber in support of the good outcome we've received. Those comments were heard loud and clear. Some of my team were watching on the webcast, and I will be making sure those comments get fed back so that the staff that did the work and do the work on a daily basis, so they hear loud and clear the appreciation and the value that you recognised that motion last night. So I want to start by just saying that. As far as going forward, we have a thing called, what we're calling the CQC Oversight Group, and that is meeting next week. And that's where we're really going to start fleshing out some of the detail of how we want to work on some of the areas we want to take further for improvement and putting a timeline to that. So I wasn't planning on spending too much time on that, but I do give you a heads up at the end of the presentation about where we're going. But it is this Scrutiny Committee's absolute responsibility to hold me to account and hold the Director to account for the performance we have at the moment, for ensuring that we sustain that performance, and really our vision and ambition to try and continue to improve that performance. And so this is a slightly longer presentation than many are going to be getting. It's a slightly longer deck, but I'm going through it in a little bit more detail because I think that you need to see that. And then if there are questions you've got at the end, I'll try and answer them. If not, I'll take them away and answer them in writing, if that's okay. So if we could move on to the next slide. Thank you. I thought it'd be useful for you to see a national picture, just to understand where we sit. So when I wrote this slide, which was back end of last week, there were all 153 authorities with an adult social care responsibility have been contacted or are in process or have had their inspections completed. 126 site visits were completed, 71 reports published. That is now 77. So they went and published a few on Friday. So there are 77 reports published. There still remain 2 outstanding. I can't quite tell you what the figures are in the middle. The majority of the 6 added, 5 of them are within the good or requires improvement. There are now 2 inadequates. So East Riding in Yorkshire has been judged as inadequate as well, and that's alongside Blackpool. But we have done the scores analysis. I'll come on to the domains in a minute, but there are 9 domains and each domain gets scored. Within that analysis, as Councillor Hooper mentioned last night, we still remain within the top 10 to 15% in the country. I thought it was just useful. Some of you will have heard a little bit of this last night, possibly. But I just think it's worth you just getting an understanding of the national picture of emerging issues. So the former DAS, Director of Adult Social Services at Hertfordshire, is now Chris Badger, is now the Chief Executive of the Care Quality Commission Inspectorate. And he came to speak to the ADAS Eastern region, which we're members of, a week before last Friday. And he wanted to test in front of a friendly audience that all knew him, kind of the presentation he's going to be going around the country, giving to all the other regions. And so he went through with us a number of the emerging themes which are coming out nationally. So there is an issue nationally coming through these inspections around addressing the issues to support unpaid carers. You'll all know what I mean by unpaid carers. So they're generally people looking after their family members, friends, loved ones, doing it voluntarily because they love their families, friends, and they need support. They're really important. If I'm honest with you, the whole adult social care system would be in a really challenging position if we didn't have unpaid carers. There are about 6 to 7 million who identify themselves as unpaid carers in the country at the moment. And so it's a significant resource that we rely on. We work really well here to support our unpaid carers. So we have a carer centre. We have a number of thousand of carers who get a carer's assessment and receive services to support them in their caring role, including respite for the carer, which is really helpful. I did mention to staff this morning, we had an all-staff briefing this morning, I did mention we are looking to extend our wellbeing offer to staff in the council because there'll be staff members here who've got caring responsibilities, and we are going to extend our wellbeing offer to try and promote staff to have carers assessments. And so that's something that I've spoken to the care centre about, and they'll come and sit in the cafe downstairs. And that's something we've just got to get moving in the new year, hopefully. Equity of experience and inconsistent use of data is something which we did, which is an issue across the country, and it's the one area we got scored lowest on here. I'll come on to the scores on the next page. So that's now I'll pause. I won't dwell on that here, but I'll come back to it a little bit when we go through. There are national concerns around supporting prevention with an increasing reliance upon the voluntary community sector. And, prevention is absolutely core to what we do now and to the future sustainability of both the health and care system. So I will come back to that as well. Safeguarding practice is inconsistent nationally. Here, they recognise significant improvements in our safeguarding practice, both within the council staff, looking after what they call Section 42 inquiries, and across our partners, and the role of the Safeguarding Board here, which is independently chaired. So that comes out strong in Thurrock and as good. But there are concerns nationally. Nationally, there are concerns around preparing for adulthood, which again got actually quite a good press within our CQC assessment report, but it's an area which I'm really keen to explore, look at if we can do things differently in that space. I'm looking to see whether we can take a more of a whole family, whole life, whole age approach to that, to look at young people, so that you don't have these kind of rather false cut-offs in age between 18 and 25, and so I can expand on that if you want me to later on. But I've started talking with Sheila. Sheila Murphy is the Director of Children's Services, and we've done a draft statement of intent for scoping a piece of work around that over the coming months. So if we move on, the inspection, you remember some of this from the first presentation, I won't dwell on this too far, but it's 4 themes, which are how Thurrock Council works with people, how we provide our support to people, how safe the system is. I mean, one of my biggest statutory duties and your most biggest statutory responsibilities is ensuring the safety of vulnerable adults. And remember, this cohort, we're not just talking about older people, we're talking about people with disability, we're talking about people with sensory impairment, we're talking about people with learning disability, autism, so it's quite a broad group of people. And then we look at the leadership. They look at the leadership. That's not just within the directorate, that's members, that's system leadership with the NHS. And there are 9 quality markers, and each one of those quality markers gets scored. So next slide, please. So there you can see, we got a really good, solid rate, good rating. We were Essex County Council, Southend and ourselves have all been inspected this summer. Southend and ourselves were both announced on the 29th of August on the same date, and Essex was about 3 weeks before us. We're all good. That's really positive that we're all good. And we all work really well together to try and discuss things. We do things differently. We're not doing things all the same. And our challenges are different. We've got different challenges in Thurrock from certainly some parts of Essex. But we're all good. Our score was just slightly the highest. Get that in. And against all the 9 domains, we scored 7 of those as good. The one I've mentioned, equity and experience, we got a 2. Partnerships and communities, we scored a 4. And so that was not just our working arrangements with the NHS, that was part of it, but it's how we work with our communities, how we work with the voluntary community sector, how much we listen to their voice. So that was really pleasing to see that one come through. Moving on. So a bit more detail. So the quality markers under how we work with people was looking at how we assess their needs through the assessment process, how we support people to live healthier lives, and then the equity and experience and outcomes. Remember, my biggest outcome would be for the majority of people not to ever come near our service, because they would want to live as independently as possible with a quality of life which doesn't require them to have our support or interventions. So living healthier lives is really important, and I'll try and avoid saying it because it's going to steal the thunder later on, but I'm going to really link this. We are so closely linked to the NHS and the whole neighbourhood health agenda, which is potentially really exciting for Thurrock. I would argue more so than anywhere else, because we are so progressed on that journey. There's a real opportunity for us. So if we move on, there's a little bit more detail on this. So the areas that we need to look to improve on around the equity was, we are not that great at the moment in providing a lot of our information and processes in a range of formats which support the needs of people with a range of impairments. So we need to look at doing that better. We also do not have really good data at the moment. So Ruby's team in public health within the directorate are leading on the preparation of the joint strategic needs assessment. And that is the overarching picture for the borough as to what the population looks like, demographics, health issues, housing issues. It's a really important oversight document. It's not been refreshed here for the best part of 10 years. And just to nail, we're going to have better clarity going forward. That's the overarching one. There are then individual needs assessments. They have been called here individual JSNA. So you've seen common mental health disorder, JSNA. You've seen a substance misuse, JSNA. We're going to change that because I think it's confusing. So we're going to move towards the joint strategic needs assessment is the overarching piece of work. Then we look at identifying individual needs assessments which need to be undertaken on an annual basis. I think that better use of data and better collection of data will help us to then inform how we address the equity agenda better going forward. There were some delays around our assessments, particularly in occupational therapy, where we were having some waiting times. They're reducing, but there are delays. It's busy. It's a busy service. There are 3,500 people in receipt of long-term care at any one time, and that can stretch, depending on how you look at that, can stretch up to near 5,000 if you broaden out the cohort of people that we're looking for. We look after a lot of people who are just on the cusp of support, and we're trying to keep them away from the statutory interventions by working in a preventive way to try and support them to sustain their well-being. What's working well, though, is our integrated access and our person-centred strength-based assessments. We have 4 locality teams here. Everyone's heard of, and probably most of you have visited the Corium Medical Wellbeing Centre, Integrated Medical Wellbeing Centre. We are looking at a way that we can try and find integrated touchdown provision in the other 3 localities for staff to be able to come together across multidisciplinary groups. But we are not likely to get the funding for another integrated medical wellbeing centre in the same way as Corringham is. Though I just pause and say the neighbourhood health agenda maybe is a vehicle for that in the future. But what we do in the locality so well is that the people that work there, linking with the voluntary community sector, the local organisations, the communities, they know what the assets are in those areas, and they utilise those assets to make sure that people access those as effectively as possible, as early as possible. And people tell their story once. One of the whinges in my world for 20 years has been, I go and see an occupational therapist, I have to tell my story. I then go and see a medical professional, I go and see a nurse, I go to the hospital. Every single time I have to tell my story again and again and again. And this way, we get to a point whereby the individual tends to tell their story fewer times. We've not quite got to tell it just once, but we're getting there, but they tell it fewer times. And people are joined up. The professionals sit together. That's really important. They sit together, they talk with each other. It's it works really well. The Urgent Community Response Team came out really strongly in this. This is a team we have which is borough-wide. It doesn't sit in the localities, but what it does is if you're diabetic and your bloods have dropped, and if you don't get sorted out really quickly, you're going to end up in hospital. This is a service where the nurse could contact within 2 hours and they'll be there to support you. So they can support you over the next 24, 48 hours to lift you back up, which avoids a hospital admission and avoids you staying in hospital for longer than you need to if you do end up there. And actually, it just gets you back on your feet again, gives you that quick 24 hours of care whilst you get your meds sorted out and you're back on your feet. It's a really important service and we're achieving a really good outcomes with that. And care support. The carers they spoke to, they really like the service they get here. They think we're responsive, they think we listen. I start my day, as some of you will know, every morning with 2 large Costa coffees. And I regularly meet the carer service lead in there, and we have these conversations over a cup of coffee. And that's where the ideas come from for the wellbeing offer for staff in the council here. And you know, she throws ideas by me and we talk, and it's really, really useful. So that's just a little bit on theme 1. Theme 2, I'll try and speed through this a bit. Providing support. So the 2 quality marks here were care provision, integration, and continuity, and the partnerships and communities, which I've mentioned we've always scored very highly on. So let's just go to the next one. So the data gaps, that linked into some of the equity stuff as well, and the work that, and partly the work that Ruby and the team are leading on around GSNA. But also, there's lots of data we do collect and gets thrown at us, but we don't necessarily use that intelligently. So we're trying to be, there's an opportunity to just use that data more intelligently. We need to work on complex dementia. Dementia and mental health are real challenges. Yeah, we have a younger population here than in many parts of Essex. So the mental health is a real issue. Since COVID, it's been a real challenge. It's one of the areas which I'm really keen to explore as to whether we can break down the age distinction between children and adults, because there are a lot of children who, aged between 11 and 15, went through COVID, didn't get the support they possibly could have been entitled to or been desirable, and are now reached that adulthood threshold with challenges. And there are a lot of people that were actually receiving mental health services as younger adults, and those services stopped through COVID, and they continue to struggle. We forget what the impact of COVID was, but we feel it very much in our services, particularly in mental health. So that's still a big issue for us. And we have a smaller older population, but the older population in Thurrock is ageing. And I went the other week to visit a drop-in service, dementia drop-in service in Headon Hall. And it's just wonderful just going and spending some time with those people and seeing how they're being supported. But we need more access, we need more facilities and support sessions. Employment support, I mentioned earlier, it's all about independence and quality of life. The more we can get young people or working age adults in our services back into employment or into training or education, the better. And we've got a really good reablement service, which is having really positive outcomes as far as reducing, for a lot of people, the ongoing need to have long-term care and support. So now if you come out of hospital, you go into our reablement service. You don't just go to a home care provider, you don't just go home without anything. And that reablement service then works with you for a period of weeks. I hesitate to say up to 6 weeks because people think that's the default. There's nothing in law which says that they get free home care for 6 weeks, but it's become the kind of the national standard norm. But sometimes it's a lot less than 6 weeks, sometimes it can go up to 6 weeks. But the idea is to work with people to optimise their independence so that ongoing, they either have no ongoing need or it's at least reduced. Which saves us money, yes, but more importantly, or as importantly, it's actually giving them a better quality of life because it's maximising their independence. And out-of-borough placements, I think you've seen the supported accommodation strategy. We do need to do more work on bringing people who are placed out of borough back into the local area. Some people are out of borough for very good reasons. Their families may live distance and they want to be near their families. But there are those that are placed out of borough because we don't have the facilities to meet their needs here. So we have a housing strategy, a supported accommodation strategy now, which is going to take a long time to deliver, but it's there now, it's in place. And we can look at, for people with learning disability, look at clusters of developments, 3 or 4 or 5 units together. You've got your own front door, you've got your own tenancy, and we have floating support or on-site support nearby. And we're looking to create more and more of these schemes as we go forward. But what's working well at the moment is the list there. The partnerships, I won't repeat that. You heard me say it first time. We do work really well with our partners in the NHS. I don't just mean the ICB, I mean NELF, the North East London Foundation Trust that provides the community services here, EPUT, the Mental Health Trust, our GPs are in primary care. We do have good communication with them. We've got great integrated support working with the wellbeing teams, with pharmacy and housing. So I've got a health need, but actually I also want to find out some advice about my debt or my rent arrears or all those kind of issues. We try and do that as a front door service to make it more holistic. Market development, we've got a really good commissioning market here where we've got a lot of micro enterprises, much more than anywhere else in the country, which are really strong. So you've got your standard commissioning offer of nursing homes, home care, care homes, support accommodation, but here I like to go fishing. So actually, that would really help not me actually, but this is the example I like. Someone who had mental health issues, they enjoyed fishing. So actually, we found them an opportunity whereby they develop their own micro-enterprise so that other people that might enjoy fishing and the kind of the solitude of it and getting away and just the mindfulness of it, they go and do that. And it's become a little micro-business. We've got 150 plus of those micro-enterprises in Thurrock, which is really impressive. I mentioned about the support for carers and the fact that I think we can do more on that, but we're working well. Moving on, please, Kenan. Safety. So this is where I mentioned the fact that, next slide, yeah, I think we're doing okay on this side. We've got good safeguarding systems. They were criticised 2-3 years ago as not achieving the outcomes we should be getting for the people. That has really improved. The timeliness of doing safeguarding assessments. We have a triaging system, so as soon as something comes into the safeguarding team, it's triaged to see how urgent it is, what the risk is, and we are really on it as far as making sure that we get that addressed. That got through my editing. Smooth transitions. I don't like the word transitions, so we are really trying to push to the terminology around preparing for adulthood. Yeah. But I think we can do much more around that. So we've got the data. We know generally who lives in the borough. Some families will move in, some will move out, but generally people stay here. And if I've got a child who's got a serious physical disability aged 9, 10, 11, and then we need to start planning for them, because if they're going to need specialist accommodation come 18, it can take 4 or 5 years. So we need to make sure we start the transitional work, preparing for adulthood work, at an appropriate age. So we're going to do much more mapping of this. And we're also going to start looking at how we could work in a different way so that we can manage the expectation of families who get really nervous because they're used to their child being really well looked after and really well supported and lots of resource and everything like that. Suddenly their child turns 18, the legislation changes, the Children's Act goes, the care Act comes in, and the resources aren't there in the same way. And we need to work with parents and families to understand what that impact might be for them and work with them through that in a much more holistic and engaged way. So I think it's a really interesting piece of work for us to do. And, you know, we do the strong multi-agency work. I won't push that. Moving on. I'll probably take up too much of your time, so we're getting towards the end. Leadership. Next bit. So, improved governance. So, we have strengthened, without a doubt, and CQC saw it, the governance arrangements. I think it was really positive on the our Common Health Wellbeing Board in another presentation, so I'll leave that bit. But I think that just at the time of the inspection, the council took the decision to, when I arrived this time last year, I think Scrutiny had a very, very broad remit. It was the People Over the Scrutiny Committee, and I think the meetings were really good, and the engagement from councils was really good, but the breadth of what you had to cover you're struggling. I think it will work better having a health and adults and health overview and scrutiny, and a children's overview and scrutiny. It'll allow greater focus, and it'll allow you to also really get on top of the statutory responsibility you have around the health overview and scrutiny function. So I think that's really positive. I'm not going to read through the list. You can see it there, and if you've got any questions, you can come back to me on it. But we do have they recognised close member engagement. That came through the inspection. They saw all the political groups. They did mention to me specifically, it was nice to see the way you communicated in an engaged way. There were mature conversations about what the challenges are that you face, the challenges in the health agenda, but a kind of almost a cross-party approach to wanting to address that. And so that was a specific comment which was fed back to me from the inspection team. Co-production is something which is embedded into a lot of what we do. I'm going to actually hard bake it into everything that we do, even including our recruitment procedures. So I want to have co-production in everything we do. I want to engage with communities, and this links back to the new corporate improvement plan, which talks a lot about talking to our communities, listening to what they want to see. And I think we should be doing that just as a matter of business as usual. Then, if we can develop those relationships and we don't do some of the things the community want, at least we can explain why, which is so important. So I think most of the time we'll be able to, but sometimes we need to just be able to have that trusted relationship so we can have the difficult conversations as well. And I think, well, let's just move on to the end a bit now. You've heard me enough. So in summary, We've evidenced that we've got good collaborative working with healthcare services, and we put the individual at the centre of our conversation about their care. People did say they felt listened to, respected and confident in the skills of our staff, and I will give a shout out to all of our staff. As you said it yesterday, I'll make sure that the staff who actually deliver the services, who are the ones who really deserve the credit, get the full feedback of this going forward. We are doing a celebration event for our staff, just a floor lunch. They're going to bring their own food. It's costing us very little, but we're doing it in CO12 and beginning November. 3 weeks' time, I think it is. And so they'll just come, there'll be a little bit of celebration. I'll give them a quick heads up. I'll give them a bridge version of these slides just so they know what was so good that said about them, but that we're not going to rest on our laurels. We're going to be ambitious for the future. So these are the areas we're going to be working on, which we've got to develop a bit further. I've mentioned about reablement and the urgent response teams already. I've mentioned about the carers. I've mentioned about the partnership working. So I think I've done all of that on that slide. I'm trying to engender a culture within the directorate, which is one where I've said to people quite openly, the culture is non-hierarchical in the directorate. Anyone can come and talk to me, any of the other senior leaders. It may take you a bit of time to get a response to my emails because I get a lot of them, but you can come and talk to me. I would like people to love each other because we'll get more out of you if you love each other. I don't expect it all the time, but what my bottom line is that everybody treats each other with professional respect and courtesy. As long as that's the bottom line, then I'm going to try and build from that. And I'll tell you how it's going next time. I've got another road show on Tuesday morning where I'm going to be giving a focus to that. We'll see how we get on. Last slide, and then we're there. So immediate next steps. That's a different way of saying we're looking at trusted assessment. So the top one, I really do want to look at doing more trusted assessment, which is where we give assessment responsibilities to our other providers and organisations, and we provide the assurance that the quality is good. We are putting in additional resources to bring down the waiting lists on assessments and OTs. Digital is going to be a key part of the agenda. We're writing a directorate plan at the moment, which will come here at some point next year. And, but we need to look at transforming our services. And then once the services are transformed, what digital tools can help support that transformation rather than using digital as the transformation. I've mentioned the community engagement, and I've mentioned the continuing to build upon the successful partnership working to sustain an integrated model. Was that the last slide? No. Yeah, I thought it was one more. So that links to this one. The neighbourhood health agenda, I think, is a real opportunity. And you're going to, I won't spend more time on it here because you're going to hear about it every meeting. I'm going to keep coming back to it, and I'm hoping I can show you progress on that space. I spoke about the preparing for adulthood. I spoke about the co-production, the commissioning offer, and then just you are aware, I think, that we are, as a council, developing a roadmap, the operating model by which this council will function going forward. I need to make sure that what we do in the directorate isn't seen as possibly some in the past may have seen the directorate being a little bit off, doing its own thing and not being part of the corporate machinery. We are absolutely part of the corporate machinery. We are one council, and this directorate will work to demonstrate how, in what it does in its own specialist way, it is also working with all the other directorates who support our work. We should support their work. I just mentioned a quick shout out to Ruby, who I'm really glad that Ruby's joined us. But public health has got a function, yes, within the directorate, but across the whole of the council and across the whole of the health system. So we need to work out how we are going to operate in the context of the corporate and improvement plan across the council and with the roadmap. And through that approach, we're going to transform our services, and the journey is going to be exciting going forward, I hope. I will leave it there and say thank you very much, and I could take any questions on this one. Thank you.
Thank you, Rob. Thank you. Yes, I think, well, you did mention it a few times, but I'd like to say it again about the staff. And I was fortunate enough before the CQC to go around some of the centres, the Friendship Club I went to, and Collins House and Pigs Corner, and they were all lovely. And they seemed really happy as well in their work, and it was really good to experience. So yes, unfortunately, I don't know all of their names to mention them, and I wouldn't want to in case I missed someone off. So it's a general good thanks and thank you there. Yes, so obviously we got the strong good, and there are the good points there. I think the areas I was going to ask about for improvement, I think most of them you did mention. And just a couple of things is the workforce challenges, and that was picked up with you said there was a bit of a delay with the OT assessments. How is that going with the workforce there? And the engagement and the accessibility. So I know you said that you were going to try and get things more accessible on the website and things like that, but it's actually engaging with the diverse communities, the hard to reach communities as well. So those are my main queries, and then ultimately how you're going to be monitoring these actions that you're putting into place, please. Thank you.
Let's do those three. So the workforce strategy. So we had a workforce strategy which was part of the information response to the inspection. What that focused on was mainly our internal workforce. But what we need to do is we need to look at how we engage and interact with. We're a largely commissioned out service. So our care homes, we've got 13 care homes. 12 of them are commissioned out to the private sector, and then we've got Collins House that you visited. We've got our home care contract is with 4 primary home care providers, and then there's a list of specialists who are aligned to each of the localities, and then there's a backup provider, and then there's a number of specialist providers. That's a large staff group. You'll be aware that staffing within the adult social care sector is a national challenge. It is generally a low-wage, low-value sector, which really undermines and undervalues exactly the important work that staff do in this world. But one of the challenges we have is the fact that I work as a care worker, and I quite enjoy it, but I hit a ceiling quite low down. I can't go anywhere. So, I can go and work for the NHS. I get the NHS badge. I can get the branding, that kind of the greater kudos, and I get a career path that goes with it, potentially. So one of the things we're looking at is looking at how we can have more blended roles across health and care, medication, providing medication, providing simple procedures, wound care, things like that. So could we blend roles and develop career structures so we give a career pathway for anyone that comes into care from an early age and actually decides they want to stay in this for longer? So that's one of the things we're looking at. I've been taught, I started having conversations potentially with Essex College and with the schools around trying to make it an attractive option for children vocationally, young people vocationally, to think into this sector. So I think there's a big piece around the blended roles. There is also all the work around giving people great opportunity to just go and taste it, have apprenticeships, work placements. So we're going to look at bringing those into the workplace here, so we can give people more opportunities just to test and try it and see what they think of it. The accessibility. So I think that's going to be delivered largely through the locality working. In time, I'm going to be asking committees if they would like to change the terminology to neighbourhoods, to the neighbourhood agenda, because I think that might be easier for the public to understand that that's what we mean. So Ruby's team are currently working on developing area profiles for the whole of Thurrock. They're just about there. They are really impressive. What I want to do is I want to go to the areas and I want to say to area forums, a bit like forums which have started, but go into those areas, have these forums, but not lecture, not preach, not say, this is your area, this is what you look like, this is your demography, this is your employment, these are your health issues. There'll be a little bit about saying this is what the area profiles are saying, but actually tell us what your assets are. Tell us what the community facilities are that you really appreciate. Tell us about people on your street who could really contribute something. So it's a two-way conversation. We learn from them as well as to what their assets are. And we engage, because the local people, they know the communities that we struggle to get. I don't use that term hard to reach. We're just not doing the work correctly to reach those people that we don't engage with. The local communities know who they are. They know how to access them. So let's get in, let's get amongst the weeds and let's talk to people. That way we'll find out the groups and the people that we really need to speak to, rather than your traditional voices that we always hear wherever we go, that we want to try and still listen to because they've got a very valid opinion, but we want to think beyond that. And so I think the forums, the locality work in the area of profiles are an approach into that one. And then you asked about performance. So we have a new performance framework being established, which is more meaningful for the directorate. And so it's powered by Power BI, which in my terms, for somebody in my age, it makes it really easy and visual for people to understand exactly what the performance is. So I can show any of my team on a single day how many people are in our services, what they're receiving, how much we've spent this week, all that kind of oversight. What I think would be really useful, though, is to get to a point whereby we collect information which is meaningful to the local communities. So what are the outcome measures? Because I don't want to go into it here, but I'll give a flavour. Health and Wellbeing Board recently received a report from LEDA, the LEDA report. Now that goes into, looks at deaths and serious incidents amongst the learning disabled community. Now then, one of the frightening things is our NHS health check performance is actually not too bad in Thurrock. It's shocking for people with learning disability. It is really low, the number of people with learning disability who are getting their NHS health check. So for me, that's a key thing we should be looking at to try and improve the performance of that. Satisfaction, I set the challenge today in a meeting this afternoon saying, we know that our integrated work is really good. We know we get really good feedback anecdotally. Yeah? Where's the evidence? When somebody, I'm setting myself up here, when you say to me, demonstrate to us that integrated work is working really well, where can I demonstrate to you that actually diabetes is being treated earlier, cancer awareness, and cancer diagnosis is being upstream so that people are being screened better. COPD, coronary heart disease, cancer, diabetes, and weight management. They are the things that we need to tackle. So my argument would be that we need some outcome measures that the public can relate to, which demonstrate that. 22 years ago, if I could just give one answer, 22 years ago I was involved in a BBC programme called Making Slough Happy. I had probably one of the toughest gigs of my life, was a job as the Assistant Director of Culture in Slough at the time that Ricky Gervais was filming The Office on Slough Industrial Estate. And Slough was getting a really bad image and reputation. We did this programme about making Slough happy. And it was really interesting because what people want is they want to, so it came out with things like, say hello to somebody you wouldn't say hello to. Phone up a family friend and have a chat. Phone up a family member once a week. And there are little things, buy someone a bunch of flowers. Have a conversation with them. There's little things which you can do which really improve people's well-being and make them happy. Why don't we have a happiness index which just looks at whether people feel happier this year than they did last year? And you could do it on some kind of spidergram. So there may be stupid ideas. I maybe shouldn't be saying them out here, but you get me going. So these are things which I will talk about. And I'm happy to be shouted down, but they're the kind of things which we'll be talking about within the teams and with NHS colleagues. Because NHS colleagues, they won't mind me saying this. The NHS is so data rich, but intelligence poor in how they use the data. It is a real, they would accept that. We collect tons and tons of data in the NHS. How much of it is really used well to inform the services that we're delivering, where we should be delivering them to, and what the outcomes are, and how patients and service users feel about it. So I think it's probably taking a fresh approach to performance and looking a bit more of a kind of an outcomes-based approach and then working back from that.
Thank you. What I'll do is I'll open it up to committee members for questions now and then come back afterwards. So we've got Councillor Fish.
Thanks, Chair. I don't really have any experience of CQC, but do have experience of Ofsted. So I'm wondering if the process is the same in terms of you have your rating, your grading, and then you have action points to improve the school. If it works the same way for CQC, I'd like to know if you think it's possible for Thurrock's adult services to be outstanding at the next inspection.
So the first answer is they're very different. So the inspection regimes are totally different between Ofsted and the CQC. Strengths and weaknesses on both sides. So Ofsted, effectively, as you know, Councillor Fish, tell you we'll phone Sheila up on a Friday afternoon and say we're coming in on Monday. And bang, and they're in. Yeah, they may get a little bit of heads up, but there's very little notice. They then do the inspection. Everyone rushes, does all the work, and then depend on the outcome. And we got an outstanding outcome here. But if you've got requires improvement, then you need to do an action. You need to, or inadequate, you'd have to do an action plan. That'd have to go back to CQC. That'd have to go back to Ofsted. CQC is much more long-term. So we found out in January that we were going to be in the tranche that was going to be done in the quarter one of this year. That's kicked off a whole load of work, which I explained in the April presentation. We submitted that at the end of January. In March, they notified us they're coming on site, and they didn't come on site till May. So we had a lot more time to plan and to program all the meetings, all the workshops, all the interviews, etc. Which in one way is good. In the other way, it means that you just do more and more work because you're constantly trying to feed the process. And they feel very different processes. The judgments are the same. So it's interesting. There's consultation going out around at the moment as to the longevity of those judgments, the forward judgments. But they are the same judgments. CQC to adult social care, if you are inadequate, then there will be an action plan required, and CQC will go back into that action plan. If you're not inadequate, then they will kind of, they'll allow you to address the areas that you need to feel improved. They are just changing. So I mentioned they've got a new chief executive. They've got a new chief inspector service. He got notified today that the chief executive of the CQC has stood down today with immediate effect. So I think the CQC is just going to have a little bit of time because they're going to appoint somebody else. So the Chief Inspector of Mental Health is going to take up the baton with immediate effect on that whilst they find a replacement. I'm trying to delay answering your second question, but you're not going to let me off the hook, are you? So I suppose part of me could say CQC will not, it's unlikely to come back and inspect Thurrock in the next 3-4 years. And we may be in a different situation in 3-4 years' time anyway. What I'd say to you is that I think that we are, I can't answer that, but I can tell you this, and you have my wholehearted commitment to this, is that we are, I think the journey we are on around the neighbourhood health agenda is so exciting. I think the way we work with our communities to promote their independence and well-being and to try and educate and inform them as to kind of how to adopt a lifestyle which will stop them from coming into our, a lot of them from coming to our services. If we could do that and prevent it more cleanly and better, then we could reduce the ratio of people who come through the system who absolutely need complex care and support. Because the challenge we've got in adult social care is those who have needs, the demand is not increasing in terms of numbers hugely. Mental health is my caveat to that. But where the demand is increasing is in complexity. It's people are living longer, which is to be celebrated. And their expectations are greater. So, and we've got lots of technology out there which says there's got lots of clever things which you can do to keep people well or to recover people. It costs money. So there's something about trying to reduce the quantity of people that come through so we'll have the resource to look after people to the best of our ability and the highest quality possible to give them the best outcomes. Now then, comparative to the rest of the country, if we're all going to improve, my argument is that because of where we are on the journey, we can either tread water and let everyone else catch up with us, or we can be really ambitious to say we're already up on that upward trajectory. Let's really push the parameters. Let's really go for it. Let's stay ahead. So if we can do that, we're going to accelerate faster than borough councils that are not as progressed on the journey, because it takes time to have got to the integration, the relationships we've got, etc. So we're ahead of that. So I think that we would progress quicker on that journey than others behind us. So potentially, in the language I don't want to use, yes is my answer. I sound like a politician, don't I?
Thank you. Councillor Maldoni.
Thank you, Chair. Thank you, Rob, for your presentation. I mean, this is an excellent result, and I want to begin by offering my warm congratulations, obviously, to you, Rob, as Director, and to Councillor Hooper. It's a shame he's not here. But you absolutely deserve your victory lap today and last night. I'm sure you won't mind if I acknowledge Ian Wake, our previous director, for the strong foundation that he built here for many years with the council, and it's clear that Rob and his team have built on that with focus and with energy and with commitment. So it's a good news story, there's no taking away from that. I actually went and sought out the CQC report and read it. I was a bit surprised that there was no link. Perhaps there was something. There was no link to that, because there's some exceptionally strong endorsements of the service in the CQC report. I mean, people spoke positively about the support they received. They told us they felt understood, listened to, and that staff took time to engage with them in a way that respected their individual needs. I mean, that quality of service is really hard to achieve. So that's amazing feedback. You know, leaders provided a strong and stable foundation. They were visible, trusted, and well respected by partners and by staff. So if you do get a chance to read the report, it shows it's a very strong performance, which is built on good leadership, genuine partnership working, and a clear commitment to delivering personalised care, and also to designing services with the people that are going to use them, what we call co-production. So that really came across in the report, and I think you've done a good job in the presentation. And I think it's important to acknowledge that this was achieved, this level of stability and strength in adult social care was maintained in the middle of a financial crisis. I think that shows the resilience that we had within that service. When we were in the middle of what was previously described as a financial catastrophe, despite the storm and amidst that chaos, the service remained resilient, well-led and trusted. So that's no small achievement, and it speaks volumes about the leadership team, the partnerships they've built, and the commitment of all of our staff across the system. So without wanting to take anything away from that, I do want to give some constructive feedback on the way this item has come to scrutiny. So we've had a set of presentation slides, and you know, I think you've done a good job of covering all the bases, but it doesn't support effective scrutiny, in my view. Good scrutiny requires members to be able to read, reflect and prepare in advance so that the discussion isn't just a reaction to what's on the screen and what's being said in the moment. It's based on a shared understanding of the evidence. So for items of this importance, personally, and I will look to other members of the committee and the chair and the vice chair for their opinions, I think there should be a properly written officer report setting out the context, the key findings, the actions taken or planned and the implications for improvement. I mean, you have covered quite a lot of that tonight. I think there should have been a direct link to the CQC report circulated to members in advance so that everyone had access to that full inspection findings. And really, I think you missed a trick by not doing that, because it's an excellent report. And then, you know, there needs to be time for members to come prepared with informed questions and a clear view of both the strengths and also the areas that we need to strengthen further. it's not about making things bureaucratic, it's about ensuring that the scrutiny process is transparent, evidence-based and meaningful, which is what our residents rightly expect of us. I haven't been on scrutiny since, but I was on scrutiny quite a lot under a different administration, and people who know me will know that I've said similar things. So just because there's a change of administration, I haven't changed my mind about that. There were areas for further development. I think you've done a good job of covering those, and I don't want to go over that ground. And I was very interested to hear some of the ideas that you've come up with for how to address some of those things. I think you're a very good strategic thinker, and I think I think it's one of your strengths to be able to look at a system and think, how can we improve this in ways that are going to be simple and cost effective. So well done on that. I haven't got too many problems with that. So the result's fantastic, better than expected, I would say, which I've no doubt is down to the present director and portfolio holder, and I am genuinely delighted with the result. But next time I will expect to see a proper written report to this committee circulated in advance. The direct link to the actual CQC report for all councillors. I don't know if councillors were aware that it's available in the public domain, and whether, so you could seek it out yourself, as I did, but I think really councillors have quite heavy workloads anyway. We really need to be providing that for councillors so that they can scrutinise effectively. So, really strong result, we should be proud, but the way we handle it here must match the quality of the achievement itself. But very well done. Thank you.
Thank you. Can I come back? Can I just say thank you for those comments? So I accept that, yep. And so possibly we could circulate, do you want this report written, printed? Because we could circulate it with the minutes of this. So we could circulate the link, I'm sure, I'm looking over, yeah. We could circulate the link with the minutes of this committee. More significantly, I take on board what you were saying. This is not an excuse. The report was published August 29th, and I suppose it's going on for 2 months. This report doesn't finish here, by the way. So this is going to be a living document for a period of time yet. I've not done a briefing to the staff yet on this report. We've got a roadshow next week, but then we're going to have events going on into next year. This is going to be a basis for work to come. As I mentioned, we've got a meeting next week, because we've not had a meeting next week to discuss how we're going to deal with the actions going forward, how we're going to prioritise those. So your comments are well made, and I'm happy to take that on board. But I think we were caught between the timeliness with everything else that's going on. We're in the middle of lots of other things happening at the moment as well. We're caught in wanting to get something back out just so you're aware of what the headlines were. But I take on board your comments completely, and I'd be happy to come back, next spring when we've got an action plan, it's being developed, it's being delivered. I'll come back next spring and I'll give you the report, a written report that you can properly scrutinise, if that would be reasonable for the chair.
Yeah, I mean, I'm not asking you to read, do a report now or go over old ground. We're all too busy for that, I'm sure. But yeah, just moving forward, that would be great. Thank you, Rob.
Thank you. Thank you, Councillor Maldoni. Yes, so I'm sorry I overlooked the link to the CQC report. I think it's because I've actually read the report about 4 times, so I'm just used to have read it. So I did overlook the link, but we're going to send some links out later, so we'll include that, and we will ask Rob to come back, with a plan of how it's progressing, and we can look at report structure with that as well. But thank you. Councillor Spate, please.
Thank you, Chair. Like everyone else, and we all spoke, I think, from the heart last night to pay the requisite compliments that needed to be said. I was really pleased just now that Rob talked about this being a living document, and it's going to be developed, it's going to be worked on, and it's going to be the basis going forwards, because there is a danger that, as was just said, that we're unlikely to be inspected again in the lifetime of this council. So there would, you know, I certainly come across historically authorities that then stick that on a shelf and don't worry about it. So I really think it's important that we do build on what we've got. And in particular, we do have something of a storm coming our way. At midnight this evening, the CQC's annual State of Care report will be published, and I've been privy to seeing some of the content in that document, and it's very scary. It talks about how the health service on our side, in terms of councils and things like that, have got to work really, really hard, and it's talking about significant investment in capacity and capability to meet the targets that have been set in the NHS 10-year health plan for England, which obviously is another document that I'm sure is part of your roadmap going forward. And what we're going to see happening, I mean, we've already, and it's a shame, I hope it'll be, and I'm sure it will be part of our agenda in meetings coming forwards, you know, we've got a real collapse of acute care around us. I mean, you know, in the last 3 months, Basildon Hospital, for example, has crashed from requires improvement to inadequate, and is utterly shocking what's going on there, and I see no hope of immediate improvement. And indeed, it's interesting that our MPs have got involved, and indeed Jen Craft has called for direct government intervention now into that. And that will all impact upon us, because part of what part of the 10-year plan stresses is that community services are now going to start to deliver of a lot of the services that are currently being done within the acute sector. So you're going to get more people pushed onto you from, you know, there won't just be Basildon Hospital to take care of them. You're going to have to take care of them. And that's going to come with a real risk. And I think the phraseology in the report is it's the real risk of erosion in care quality. And I'm sure there'll be a lot of discussion about it tomorrow. And it talks about vulnerable groups being hit hardest. And I was pleased earlier on when you spoke about the inequalities of some groups of people, older people, people with dementia, people with learning disabilities, and those with complex mental health needs. And it's not just across adults, it's also across children. I mean, those of us on the corporate parenting were pretty annoyed at our last meeting about the fact that health checks are just not taking place in the same way as those with learning disabilities are not taking place. So you've got a really, really challenging future coming up, and you know, it's interesting. Tony talks about, are you confident that you think you might get outstanding? I think most people in what you've got ahead of you would be more than happy to say, if you can hold good, you've done a bloody good job. My question, because there needs to be a sort of question at the end of that, is you know, what can this council, as a body of politicians, as a lobbying group, as an organisation that works in partnership with other organisations, you know, you're at the coalface, you're chipping away, you're doing a lot of stuff, and we know you've got guys and girls on the ground floor that are really struggling at the moment, and we've seen a huge churn in staff, and there's a shortage in staff. And indeed, in the report that comes out tonight, it talks about the reduction in numbers of staff to work in, particularly in the adult social care sector, and particularly within mental health. It's going to be a real problem. So, yeah, scrutiny involves looking at the past, and it involves, you know, analysing successes and picking apart mistakes. But scrutiny is really about learning. So, you know, I think we can learn a lot from what you've done. It's a tremendous achievement. But what we also need to do is to make sure that we as a council, as a wider council, because it involves many, many things, are constantly fighting to help support what you've got to do. You know, we're all aware of financial pressures. We're all aware, and this again comes out in the CQC are very, very wary of impending cuts to services, because we all know that, you know, money's not necessarily going to be forthcoming to the NHS in the way that it used to be through ICBs and things like that. So there's a huge challenge. So what, if anything, do you think the council needs to prioritise to give you the backing that your service needs to be able to hold that good and hopefully well, not that you're going to be, but hopefully, you know, to at least be, well, you always aspire to be outstanding. I know that. I know from many conversations with you, that's your, you know, that's your benchmark, and even above and beyond that. But do you think there are any things that we as a council and this committee as Scrutiny can dig in, lobby, fight, speak to MPs, put pressure on other organisations? You know, we're here to support what you do. So what do we need to do?
Thank you, thank you. The challenge is an interesting one. My immediate response is to look two ways. So I'd look into the communities and what you as the elected members of your constituents in Thurrock to lead on going into place, using the area profiles, using with the intention we've got to engage that conversation with the communities as to what they would like to see, what would it be that makes it better for them, so that we can not me have a couple of good ideas or my colleagues have a couple of good ideas, but actually get the ideas from them, or the concerns from them, that we can then develop the ideas from. So I think something over the next 6, 12, 18 months, whatever, about real community engagement and listening so that we can respond to those concerns is a role we really welcome a member's support on. The flip to that is to say, wearing your councillor hats, looking at that system, looking at the wider regional, national politics of the neighbourhood health agenda, which is one which I would argue is not particularly party political. There's strong support across groups for the work for there's a thing, everyone knows Left Shift. Left Shift is the NHS 10-year vision, and it's three things. It's about moving from acute to community activity. It's about prevention and upstreaming of activity. So rather than treatment, stop people from getting ill in the first place. And then the third area is around kind of what digital technology can be used to support all that. Now, that is something where I think we need to engage in a dialogue with our system partners in the NHS and other colleagues and say, we know it's challenging, we know it's tough, how can we work to help you? Because I've had conversations with the hospital recently. They are really keen on the journey there are benefits to them of moving some of the activity into the community. And the benefits to local people. You know, 2 weeks ago, week before last, we opened the diagnostic centre in Grays. It's potentially a really valuable resource. It'll stop people from going to the hospital to have all those diagnostics. So it frees up a bit of capacity in the hospital to do what they should be doing, what they're meant to be doing. And it's giving a facility that's more local for people to come and have all their diagnostics done in the community. How do we support primary care? And there is an issue about GPs. It's been well versed. We know we've got the lowest ratio of GPs per head of population in the country. So yes, there is an issue. They take time to train, but there's also looking at allied health professionals and how they could work better, pharmacists, community nurses, etc., etc. So I think there is something about using your role in the community, but also to say to the senior system leaders in the NHS maybe, we want to place is really important. So, you know, your priority, I would guess, is about Thurrock, yeah? So ensuring that Thurrock's voice gets heard at the table where the decisions are made about resources, about kind of what's going to be the priority around health inequalities, what we want to address. I just mentioned that, you know, it is around cancer, diabetes, coronary heart disease, COPD, and weight management. If we could really have an impact in those areas, we would really shift the dial in a hugely preventive way, and it would match the overall. It would make a big contribution towards the overall well-being of the whole population in Thurrock. So I think it's something about kind of saying we'll stand up to be a critical friend stroke challenge, and we want to work with you and help. That would help me in the conversation I have with the NHS, because they want to do the right thing. They do genuinely want to do the right thing, and they do want to work together, but I want to support them in that space, along with my DAS colleagues in Essex. You know, in Essex and Southend, I speak a lot with Mark and oh, then the name goes. I'll meet him first thing tomorrow. Anyway. So, you know, we want to work as a system more effectively, yeah? And so to give us that support to be able to do that is really good.
Just respond.
Of running to time, so one just quick
Right. Well,
question, please.
just to make one quick point. I mean, it was really interesting that you touched on getting feedback, but also a two-way message with our local communities. And I think we, as a scrutiny committee, maybe sometimes become too insular and we just focus on the word health. And I would hope that, you know, when we consider matters, it may well be that we tried to do it in corporate parenting the other week when we tried to stick a foot through the door of children's services. We didn't really get through that door, but at least we tried. And I think, for example, we could maybe do a cross-committee message to things like corporate and say, you know, can you do some analysis, because it's your area of expertise, on communication? Because, you know, I almost think you guys should have your own communication department because it's so specific and you've got such a huge amount of messages to get out that a lot of them are getting lost. I mean, I don't think it's any great secret that our comms isn't the best in the world. Our website's not the best in the world. We don't have great dialogue with a lot of our residents. It's something that's happened over a number of years. But I would just ask, you know, all colleagues, if you like, sort of trying to answer your question, all colleagues, all 49 of us, we look at how we can lobby, be critical when we need to be, and get that and share that thing, you know, and not just focus on health, that word, but focus on the whole targets, the whole range of targets that you've got. And I think communications is one that I can certainly say today we can do a hell of a lot better. So, sorry, thank you,
Can I
Chair, for your
just say
indulgence.
one thing? So I agree with that. Can I just give a quick shout out to Nick Presberg? Sorry, Nick, I forgot your name. So Essex, the Essex DAS. And just one thing, just to finish off on maybe, because this is something around the preparing for adulthood. So I've mentioned what some of my thinking is around that, but it's about who we actually engage with in that process. So at the moment, you've got a defined cohort of younger people who've got mental health condition, physical disability, learning disability, etc. What about if we were to work more effectively with the 550-odd local looked after children care leavers in a kind of a more engaged way? So we work with them more closely around training, employment opportunities, how to manage a budget, how to support yourself in your own accommodation, those life skills. I just think there's a real opportunity. It may not be in the PFA work directly, but that would be a huge thing if we, and it's just kind of what Councillor Spate was mentioning about our corporate parenting role. If we took that, not just about kind of keeping them safe, which is absolutely fundamentally important, but actually about trying to support them in the life skills to allow them to be independent, then imagine the benefits that we get long-term, DWP get, police get, etc., etc. It really has a huge benefit. So I just want to mention that because that is within the scoping of the work.
Thank you. So I'll just go to Councillor Day, please.
Rob, I echo the praise from Councillor Maldani. I think it's you've done a very, very good job, you and your team. And but you have said, you know, we have to scrutinise you. At the beginning of your speech, scrutinise me, scrutinise me. Well, I see in the report 88% of social work practices were rated good or outstanding, which is great. And you talked about looking to the future and moving on and let the others, rather than waiting for the others to catch up. So what steps are being taken to address the remaining 12% of the practice that did not meet the threshold?
Let me give you a direct answer around one specific. So we are not where we need to be on reviews. Yeah? So we have a statutory duty to review every service user on an annual basis. No one in the country actually does meet it, because some people, their care needs change or they pass away or whatever. So from a statistical point of view, it's very difficult to get 100%. But that's one of the areas that we do need to improve upon, yeah? So one of the pieces of work we're doing now, and it kind of links to the roadmap work. But I've initiated we're doing a system mapping process for every service. So our assessment service, our financial review service, our reviews, our safeguarding, we're doing a mapping of every process at the moment to see how we do it now, because everything changes. The population here changes. You know, the demographics have changed significantly in the last 15 years. So are the systems and the processes that we use now, which were designed 10, 15 years ago and developed a little bit, but basically not been changed for 10, 15 years, are they still the appropriate processes for now? Because if not, then let's look at a different way of doing things. So my little strap line at the moment is, yes, we are a statutory service, so we are required to do certain things, but nowhere in statute does it say we have to do it in the way that we do it at the moment. So we're doing a process mapping of all our services, and we'll look at what may be a more effective approach to all those services. That way, we would address the 12%, we'll be able to improve it. Okay.
Thank you. We're running very close to time, so one very quick question.
Not going to be just a quick one. Thank you, Rob, for the presentation. Right. I just came across, I read something about delayed discharges in the hospitals due to lack of community care. Can you talk a little bit about that? How can we improve on that? Thank you.
Is that an our report, or are you talking about a national thing? I think you're talking about a national issue, not a Thurrock issue.
It should be. I'm sure we have some issues because...
It's not a big issue in Thurrock, if I'm honest with you. So how it works here is we have a hospital social work team. If somebody's ready for discharge, then they will get, if they're going back to, if they went into hospital from a care home, they go back to the care home because that is their place of residence, yeah? If they are going to go back to their normal home, not a care home, then we have a reablement service which gets really good coverage in the inspection report, which will give them the care that they need for a period of time whilst we put in place a longer-term home care provider to provide them with the support. There is the odd occasion, and it should happen very rarely, it does happen, it's called Pathway 3, where somebody in a hospital bed is going to, they've come from a home, a normal home, they go into hospital because of a stroke or some other event, and then they cannot go back to their home, so they get placed directly to a care home. It shouldn't happen very often. You should always try and get someone back to their main home. In that case, there can be issues around accessing capacity in the market, because there is limited capacity in our care home market, as there is in many parts of the country. But it's partly an issue between the NHS and ourselves, a bit of an issue, because as soon as they say someone's ready for discharge, they want them out of the hospital bed, yeah? I will say, it takes a few days to get someone out of the hospital bed because we need to get a care home or a home care provider to go and see that person. They need to say, yeah, we've got the capacity to look after that person, but we'll bring them out, we need to rota them, and it takes a couple of days to actually get a service set up. So actually, there's a good reason why there's a little bit of a delay between somebody being optimised and ready for discharge and them normally going home. But I can assure you that within the Essex system, we are a high performer, and it's rare that that happens. Okay.
Thank you. Yes, in the CQC report, it does say the discharge is good, and that's part of the community response and the link up that Rob's team have at the hospital. We will obviously share the link to the report with you, and you will be able to read that. We have got some work coming on discharges. Health Watch have got a discharge report that was due to be today, but that's been deferred. And then with the NHS 10-year plan in February, we'll also have some coverage then as well. So thank you very much for the presentation and report, Rob. I think it'd be clear to see that, you know, the team within the council's working well, and with external partners as well, and that's something to really build on to help continue the preventative and community work and to strive. And we look forward to the action log to see how you're doing there. Thank you. Right, so we will now move on to item 6. This is the Health and Wellbeing Board report. This is really coming to committee to show what's happening at the Health and Wellbeing Board. So it is some quite sort of bullet, very brief points on some of the main areas that the board have been covering. We can send some links later along with the CQC report to the full reports for anyone that's interested in having a look that was what actually went in full to the board. Unfortunately, Councillor Hooper can't be here tonight, and there wasn't scope in our municipal year to move the report. So Rob is going to present the report on Councillor Hooper's behalf. If there are any particular questions that you would rather Councillor Hooper answer, we will, we can take some questions and we'll follow up with him. And I am aiming to get a verbal update from him on the board's work in sort of hopefully in February. Okay, so may I ask Rob to present the report?
So you'll be pleased to know there's only 4 slides, yeah? So I'm going to do this really quickly, I promise you. And also, I'm sure Councillor Hooper won't mind me saying that we did have a conversation yesterday. He's very apologetic for the fact he can't be here this evening. I feel slightly uncomfortable in this space because I'm really presenting an overview as an officer on behalf of a chair of a board. So I'll put it out there, I'm not overly keen on taking lots of questions unless they're kind of very much officer related rather than anything else, if that's okay. But what I just did want, what I agreed with Councillor Hooper is that I would just run you through some of the key activities that have taken place in the last year and are active at the moment. And maybe if I just give Ruby a heads up, I'll end up on the health and wellbeing strategy. So can we just go to the next slide, please? So, start with Ruby, actually. Joint Student Needs Assessment. I've waxed lyrical on that one already, haven't I? But we are in the process of preparing an overarching JSNA. That is underway. And we have established a steering group which will recommend needs assessments. So there'll be a list of kind of needs assessments that we could do. And that steering group will then recommend which ones should be prioritised. That will then go to Health and Wellbeing Board for Health and Wellbeing Board to say, Ruby, your team, can you go and do these needs assessments? Is there anything I'm missing, Ruby, on that? Does that make sense?
No, Rob. I think essentially previously at Health and Wellbeing Board, the JSNA steering group, the JSNA process was reviewed. So the way we're moving forward is very much in line with the recommendations of the board, and I think the steering group will have its meeting early next year, and we're looking forward to progressing that work and also getting feedback on how we're doing as well.
Thanks. And then the other piece of work which the board has been looking at is around the air quality strategy, which is a piece of work which is being taken place on an Essex footprint for obvious reasons that the wind blows across the boundaries. And so that work is underway with Essex and Southend Council. And we'll report. I'm not sure the date is reporting. I also just wanted to link in, because I know there are, and Ruby, I'll let you come in again if you know a bit more on this, but I also wanted to link in around because I hear a lot about the Tilbury dust concerns. That has been heard at Health and Wellbeing Board, and we are actively engaging with the Environment Agency around trying to hold them to account to address those issues, which are long-standing, but that's not an excuse for the fact there needs to be some action in that space. So we are engaged with the Environment Agency on that. Is there anything I'm missing, Ruby, that you'd want to add or not?
No, just to add, kind of mindful of the concerns around Tilbury dust. I'm in engagement with regulatory services officers to progress and also to contribute from the health perspective as well.
Can I just come in there? Yes, I've been speaking with both Councillor Hooper and Councillor Jones, who's chair of Place, about this, and we do feel that the dust issue has been going on for an awfully long time now, and that action does need to be taken on that. So I'm glad that you are looking at that, and I have been in discussion with Claire that hopefully we can look at, the next municipal year is having a report coming to this committee on the health aspects around that as well.
Thank you. Then one of the statutory responsibilities of the Health and Wellbeing Board is to receive a pharmaceutical needs assessment on, I think it's a 3-year cycle it has to be done. This needs assessment is quite detailed, and we'll send round a link, because it was, I think that we'll send round a link so you can have a look at it. It was approved in the, earlier in the summer. What it looks at is the location of pharmacies in Thurrock and the services they provide. The intention being that everybody should have local access to pharmacy and the full range of services that are provided within them. I've not got the details in my head here at the moment, but it's a very comprehensive document. It also does have quite a contextual piece at the beginning, introducing the borough, what it looks like, its future population trends, and in that context, it links very much to the Joint Strategic Needs Assessment. There will be some overlap with the information there. So that was approved in the summer. We'll send the link round. If I go to the next slide. The board, it works really closely in partnership with not only NHS members on that board, but also we have the safeguarding chairs, we have CVS, the voluntary community sector, and we have Health Watch. Health Watch do some really important work in Thurrock, and I just want to mention 3 things they did. They facilitated a focus group with children and young people to look at their health and social care priorities, and they focused on mental health in that focus group, and have prepared a report, which is something that we want to take forward and action more. They did a report exploring the safeguarding that I've mentioned earlier in their inspection report, but how truly personalised is that? So, you know, how are we engaging with the families? You know, it's often quite difficult. In reality, it's quite difficult to engage with people who have been safeguarded or in the middle of this. So how do we do it in a sensitive way, person-centred, considerate, respectful, but try and get underneath what the outcomes are that they want, and have we achieved those outcomes? As it was in the inspection preparation, I think we achieved very high outcomes, satisfaction with the outcomes being achieved there. And then they're doing retrospective reporting on access for residents into dementia projects across the borough. And I must admit, I've not read that report, but that piece of work is ongoing. They did a really sterling piece of work around the NHS 10-year plan. So the consultation on that was the national consultation on that was earlier this year. We got, I've put down here, did I put commendation? I did put commended. I don't think I've got a certificate or anything in writing, but I can tell you I had a meeting with DHSC shortly after that. And they did specifically say to me that we had, if not the highest, one of the highest response rates in the country. We got 521 responses to the NHS 10-year plan. That was from a range of individuals and community groups who therefore represent a whole load of other people as well. So it was a really positive response. It's really good because there's some stuff in that which becomes part of our neighbourhood health agenda to take forward, because we've got to be seen to be acting on it, yeah? So it helps actually stimulate and enthuse us to carry on doing what we're doing already. So I've mentioned the left shift agenda, so I don't need to do that again, but it really does help to give us that mandate for the neighbourhood approach I want to take forward. And then the board is getting regular updates now, and I'll actually do this on the next slide, from the Greater Essex ICB. So you need to be aware, the East of England is going from 6 ICBs, integrated care boards, down to 3. There's going to be a Norfolk and a Suffolk. There's going to be a huge Hertfordshire, Milton Keynes, Bedfordshire, which is quite big. Importantly for us, we're going to have a single Greater Essex Integrated Care Board. It'll be established from April next year. Work on that is ongoing, and the functions of that and the staffing of it is very active at the moment. I really can't say more. It's more appropriate for Tom Abel or somebody from the ICB to explain where we are with that. But, you know, the ICBs are going through a very challenging period, but they continue to be very engaged in our Health Wellbeing Board and are giving updates. So if I just go to the last slide. These are where I'm treading on slightly more dangerous territory, but this is how I feel, so I thought I would just express this. I feel that since I've been here in the last year, I have seen a broadening representation from partners and a consistent senior attendance. So the Hospital Trust are sending the senior leaders now, not deputies. The ICB is sending Tom Abel or one of his senior colleagues in their place. The chair of the Safeguarding Board is there. We've got the VCS on there. We've got Health Watch on there. What it's doing is it's improving the quality of discussion at the board. So they feel much more rounded, much more effective discussions. And we are planning a Health and Wellbeing Board workshop, which will focus upon our approach to deliver the neighbourhood integrated provision required across Thurrock, which a member of Ruby's team is helping to design that. That's most likely to be in December. I knew Ruby, I'd written it somewhere, which is why we discussed it earlier. I was thinking, where have I written it? But it was on this slide I did earlier today. So that workshop is coming up, and that will look at how we want to really work with health to deliver the focus on Thurrock. So just in that space, let me close this one down if I can, but it will look at how we're going to address the locality bases, what are the challenges around primary community care, Orsett Hospital, which is a really important issue for people here locally. The MSC Foundation Trust are establishing a working group, a task and finish, a 6-month piece of work, at which point at the end of that, the commitment will be to have a plan for exactly what they see the future of Orsett Hospital. Those terms of reference are being written at the moment. I've not seen them. I've not been involved in the drafting. I will be involved in that working group. And so that's looking to start towards the end of this year to report in the spring. And then just one thing on impact is that I don't think the Scrutiny Committee has had the report back, and I apologise, from, I think it was February Health and Wellbeing Board, and Ruby, get yourself lined up because I'm just about to hand over to you. But we agreed in February that we were going to align the Health and Wellbeing strategy, which times out in summer 26, and the Better Care Together Thurrock, which I've been challenged for wrongly saying is the operational plan, but it is effectively an operational delivery plan for the strategic objectives of the Health and Wellbeing Board. And that was written as well back in 2021, 22, and that also times out next year. So what we agreed at Health and Wellbeing Board in February, or what members agreed, members of the board agreed in February, was that we would align those two pieces of work, and officers would be charged to try and simplify that into one single document, because the time has moved on since that was first done. The system relationships are more mature. The situation has changed in a number of ways, and so that piece of work is currently being undertaken. Ruby, do you just want to, is there anything I've not mentioned would you like to say?
I think most of the points have been covered, that being the key one, that it's a high-level health and wellbeing board strategy that encompasses previously 2 strategies. We're in the process of pulling that together and drafting high-level principles, high-level priorities. There's inequalities is really important throughout that, and I think that's a kind of key thing to mention. And the frame of it, we would like it to look across the life course. So that's another kind of key point.
Thank you for mentioning that, Ruby, because health inequalities are a really big concern, especially in Thurrock. We have a massive variation, and that is something that the Health and Wellbeing Board are really working on. And actually one of my questions was about focusing on that in the refreshing of the report, because it is such an important area that feeds back in so many aspects of health and daily life for a lot of our residents. So I'm glad you brought that up. Thank you. Okay, that's done. Okay, thank you both, and thank you to Councillor Hooper, wherever you are, somewhere much sunnier than we are. And I know that he's very sorry he can't be here tonight. And I do thank him for his work as chair. Everyone knows that, you know, as portfolio holder, he's very, very passionate about what he does, so that's great. So it was a brief overrun of the topics covered. So there is access to further depth of them. And as I say, I'm going to try and get Councillor Hooper to give us an update. The main one for me was the refresh of the strategy, which a lot of that feeds through the work that's done and came through a lot in the CQC report as well, that all the preventative work, the interlinking, that is all in those strategies. One thing that has gone on the forward plan that I'm very excited about, which we don't know much about yet, is a women's health strategy as well. So I'm hoping that maybe Councillor Hooper will have some update on that when he comes back as well. Okay, would any members like to ask any questions, please? Councillor Spate and Councillor McClintock after.
Yeah, just briefly, air pollution has sort of come back big time onto the local agenda recently, and it was interesting that you singled it out, or Mark singled it out as a key element of the report that came through. I mean, how, silly question because I'm sure the answer is very, how seriously does the board take its weight in bringing pressure to bear to try and improve things like air pollution? Because, for example, I mean, my understanding of it is, as a council, we're obligated to produce an annual pollution report, an air pollution report. We haven't done one since 2023, as far as I can look at the figures that are available to me, and there was a recent report out that seemed to confirm that. So we need to look at these issues that directly affect an awful lot of people, and we know that Tilbury's just gone absolutely loopy-doo over the last 2 or 3 months, because they're really getting some weight behind their arguments. Tilbury Community Forum have done a fantastic job in motivating it. Their dust dashboard, I think, has been one of the key movers to make things start to happen. But do you feel that the health board itself can actually bring pressure to bear on making sure that we tackle those key issues, or is it, I hate to say it, is it a bit of a talking shop where you don't really have a gavel to bang and say, please jump? Sorry. Well, I hope I'm explained what I'm after.
Thanks, Councillor Spoke, for raising that important question. I think air pollution is important, and it's a kind of cross-council issue. We're working closely with regulatory services. We've got air pollution, air quality officer as well, who monitors the air quality. It is important for health. It's clearly recognised. Air pollution is a big contributor to poor health, and so it is absolutely an important issue that we take seriously, and we are engaging with regulatory services actively, as it's a live issue.
And just to give one specific, I mentioned earlier, didn't I, COPD. Yeah. So if we're going to turn the dial on chronic obstructive pulmonary disease, asthma, etc., those conditions, air quality is one of the issues that needs to be tackled if we're going to turn the dial on that. So we can make specifics to the strategic stuff down to, if we are going to start monitoring health improvements around certain health conditions, then what needs to shift to enable us to do that. And so I think people are listening. I think it's got some weight.
Thank you for that. I think, as I say, it's that bringing pressure to bear. I mean, it is, as far as I understand it, a legal requirement that we produce an annual report, and the fact that we haven't done one since 2023 is pretty damning of us as a local authority. But I'm sure you'll be addressing that issue. Anyway, I'll leave it there.
I might be wrong, but in the latest air quality, there is a joint air quality strategy across Essex, and we have had some recent figures. We will circulate that, I'm pretty certain, unless I've got it very wrong. There is something.
Well, that may take us back to the communication thing, Chair, because I'm on the actual Thurrock Council page now, where air quality monitoring, and it's got the list, and air quality annual reports, 2023, 22, 21, 19, 18, whatever, they're all there. But we haven't, so it may well be we've done it, But it goes back to what we were talking about half an hour. How are we communicating all the information, if it has been done?
I'm sure it came as a report to the last Health and Wellbeing Board meeting. I'm sure it did, but I will double check that and we can send that over. But you're quite right, Councillor Spate, air quality is again one of my key concerns. Councillor Maldoni.
Thank you, Chair. So this is a report to note. In my opinion, reports to note shouldn't be coming to scrutiny committees. If it's just for information, it should be circulated as a briefing note. I don't know this is just where I stand on it. If it's on the committee's agenda, I think there should be a clear ask of scrutiny, a decision or challenge or request for some input that will actually shape policy and for a two-way conversation between the boards. Anyway, we are where we are. So what I did look at is that there were some links to other information. I did actually look at the pharmaceutical needs assessment, and as you say, there's a good introduction in there that looks at the information in the JSNA, and I found that very interesting because quite often in reports we'll get borough averages, but when you actually look down into that detail and into the local super output areas, when you start looking that local, you actually see that we're not the same across the borough. I mean, we probably know this, but it's this kind of information that I'd like to see how are we using our strategic commissioning to make sure that places like, I mean, Tilbury has several LSOAs in the top 10% most deprived nationally. Chadwell St Mary's in the top 20% most deprived with the lowest self-reported health in the borough, the highest proportion of unpaid carers, lower car ownership, and very little bus service, and shorter healthy life expectancy, and also Graves Riverside has some serious pockets of deprivation with language barriers and housing insecurity, which adds to the health access challenges. Those are specific communities with very specific needs, and I think that's where our scrutiny should be focused about and how we're meeting those needs, rather than, you know, there has to be strategies that try and address the health inequalities that there are across the borough. So I did find that report very interesting to read, and I'm very glad that the JSNA is being reviewed. It's good to see the terms of reference there. I think that's a very useful document for us to have here. So some of the questions I think we should be asking when we get a report like this, or if we want to look at these things, given Chadwell's position in the top 20% most deprived areas and Tilbury in the top 10%, what targeted measures are being taken to ensure pharmacy and wider health access matches that level of need? How is deprivation explicitly weighted in our commissioning decisions? I think that's a really important place to look. And pharmacy contracts expectations for those high need wards. I mean, I know in Chadwell for a while there was a rumour that our pharmacy was going to close down, and it would have left people were very upset because it would have left people in a very difficult situation, especially those that haven't got access to cars and with a very restricted public transport system, and of course no train station in Chadwell. What assurances that we can get pharmacy access that's genuinely walkable and reliable too? That was especially for vulnerable residents, older people and unpaid carers. Why are smoking cessation referrals from the NHS Trust effectively zero in Tilbury and Chadwell? And what's being done to change that in areas where we've got the highest health burden? So it's like we're not, I don't think you mentioned smoking. Did you mention smoking, Rob? You have to remind me. I don't know if it was one, it wasn't the list. But I mean, obviously, you talked about COPD, so we do want people to stop smoking. cancer as well, even the links with diabetes. It doesn't really seem to, we're not getting referrals from those areas where we've got those health needs and inequalities. I've got some more questions, but I think that's sort of generally what I think we could have done here in terms of scrutiny. And I'm not quite sure. I get that this is a report which is giving us an update on what's happening in the Health and Wellbeing Board, and I think it's good that it's come. But how can we actually make it a scrutiny item on this committee? I think that's what we need to look at. Thank you.
Thank you, Councillor. They're really, really useful comments and good feedback for us to think through. The P&A, I think, is going to Health and Wellbeing Board, so it hasn't, I think, the next Health and Wellbeing Board. As Rob's mentioned, it's statutory requirement every 3 years. They often cover at the start a kind of wide variety. They kind of do context setting, and the P&A is used by the NHS who will approve or not approve applications for pharmacies in the area. So that's the kind of use of the P&A as well. The point you make about inequalities is really important, and with my, as Director of Public Health, that's the kind of key, that's the fundamental thing that I'm always looking at, and that is both geographic inequalities and also the other layers of inequalities that exist. We've heard from Rob today about groups of people and communities who have got higher levels of inequalities, and that is another important frame to look at. And I hope that comes through in the JSNAs and the work we do. And I think absolutely important to look at the average of where we are, as a borough, Thurrock, but the getting improvement is really digging deeper and understanding what's going on, and getting very granular and working with communities to understand why those inequalities exist. So really welcome that comment. Smoking is a challenge for us. Our smoking rates are a challenge. There are a number of public health challenges that we're grappling with, and I think through that JSNA the overarching one, we hope to kind of present that picture in more detail.
Thank you.
Sorry, can I just come in there? Thank you, Councillor Muldoon. You did make some good points there, and I think Claire and I will maybe go away and see how we can turn it into more of a scrutiny report going forward. I think the issues are, it's such a big area, and the topics you covered are huge, and there will be lots of teams working on smoking as an individual, and so there is a lot of work going on. I know it's just, I think it's like communication, it's not always that clear, and as you say, it does link in, so smoking links in with lung cancer, as does obesity, as does poverty, as does everything, so it does all sort of come under, one thing does self-perpetuate onto the other. The healthy weight strategy we have got coming to scrutiny in January, and there is a massive inequality issue there as well. So it is a huge topic, but yeah, I think, as you say, we do need to try, and this was really just the first time it's come to ONS. I think the previous Public Health Director, Sharon, thought it was very important for committee to know the Health and Wellbeing Board's work. So it is the first time it's come, and we will work on that going forward. Thank you. Councillor Manuel.
I just wanted to make a quick comment expressing my gratitude that the Tilbury dust problem is finally sort of being addressed and being taken quite seriously, because as has already been said, it's a long-standing issue, and as one of the ward councillors in Tilbury, is something that when I ran for election, it was one of the biggest things I heard on the doorsteps. It was about the dust. So I'm really grateful to the Community Forum for the work that they've been doing in trying to monitor and track it. And I just want to place on record my full support in that work going forward. And hopefully there can be some sort of conclusion, a long-term sort of solution to the issue, which just seems to have been going on for quite some time now. But I just wanted to put that on record. Thank you.
Thank you. Thank you very much, Rob and Ruby, for presenting that on behalf of Councillor Hooper. I think it was a good overview of what's going on, and it's given plenty of food for thought on questions and things that we'd like to know more on, and we will definitely come back on those. Thank you. So we will now move to item 7, which is the Q4 Provisional Financial Outturn 2024-25, which is the Adult and Health Directorate Services. This has come to committee to give an overview of spending in the different departments and the financial position across the Directorate. I would also like to thank the portfolio holder, Councillor Val-Morris-Cook, for coming this evening as well. Thank you. Is it you, Councillor, presenting? Thank you.
Can you load the slides, please? Thank you. Okay, so this is the first of 2 reports tonight, which is the budget summary for the provisional outturn of Q4. Without going through, because I know that I do notice that time is quite tight, so I will try and be as succinct as I can. The Adult and Health Directorate had a budget of 52.865 million and ended the year with a 4.12 million underspend, which was 8% of under budget. It had a savings target of 2.933 million. 96% of these savings were achieved, and 106,000 couldn't be saved due to one issue, and that particular issue was the rollout of direct debits, which really hadn't had the pace that it should have done. The capital programme had a budget of just over 500,000. 503 million of that was spent, and 90,000 has been delayed and has subject to slight slippage of 15%. To give some context on the capital programme, because when we've gone through it, on the general fund in total there was a considerable slippage, and what now we do have a capital board where I'm part of it as representatives for each of the directorates. We have had our first meeting. Any business cases that people want to address and put towards capital bids do have to go to that board now, and it has to be agreed. We are in the process of going through the current capital programme line by line, because there are still several items on there that are no longer applicable and can be cleansed off, and obviously the money's put back. So with that vast of underspend, as you can imagine, and we did have a 21 million in total underspend of the provisional outturn for last year. And, you know, if I'm being totally open and honest with the committee, an underspend of that magnitude is sometimes as bad as an overspend, because it wasn't as expected. It was what happened in Q4 that had delivered the larger underspend. So what have we done to ensure that we actually have more control over what was going on? So we are reviewing how it forecasts, and this is something that was discussed at audit. And it's not that you only forecast your budget once, as we were talking about the CQC is a living document, as is the budget. So each of the quarters you can see what the demand is, what's been spent, what the forecast is, and we can adjust as required. We are also adjusting future budgets based on the growth that was actually put in at the beginning of the budget to see, is that growth still needed? Can it be rebased, and can it be adjusted? We will have, I've got Q2 outcome coming up to Cabinet, I believe, in December. So we will know a much stronger position on where we are in Q2 as to where we can remove further growth, which only goes to help the underlying budget. I'm happy to take questions on the outturn, but I think the one that you're probably more interested in is probably the Q1, which is the next report to come.
Thank you very much. Thank you for that. So with regards to the underspend, as you say, that can bring up concerns in itself. There are a couple of comments on the CQC report that noted budget challenges as an issue, but if we have all this surplus money, why has it not been used? Is that because we didn't know at the time that we would have enough funds, or how has that come
So
about?
I can answer that. At the time, we were waiting for, I think it's the Better Care grant to be ratified to say that we could actually utilise that, which I think was just over 2.7 million. So otherwise it would have shown an overspend, and quite rightly you have to show that as a challenge before you get the ratification that the Better Care grant has been released, so you can wipe that off. So that was that. And the Q1 report will show that.
Thank you. And again, this probably come up in Q1, but to allow for sort of fluctuations and differing costs, I'd be concerned that we reduce the budget and then it turns out that something goes up as well. So
Yes.
I know it's a sort of very difficult balancing act, but that would be another
And
concern.
absolutely, and obviously, you know, as much as I'm sure the finance department would love to take every penny away that's not been utilised, I'm sure that Rob will put up a bit of a fight, and obviously Ruby now too, because he's got sort of somebody to back him up there now. But that's why we're talking about the constant forecasting and understanding each, you know, every month we look at which position we're in at the end. You know, we're coming up to period 6, so we know exactly where we are, so we can look and extrapolate forward with more confidence, and it's something that wasn't happening previously and is now, there's a lot of rigour in that because of obviously where we were, and it just makes more sense. And obviously we need every penny we can get.
Thank you. Are any committee members? Councillor Maldoni.
Thank you, Chair. Yeah, I mean, I want to begin by recognising the hard work that went into delivering this outturn for last year. An underspend of 4.12 million, 96% savings delivery in adult and health is no small achievement in the current climate, with the savings that you were having to look at as well. It does reflect discipline management by officers, and we did lay some strong financial foundations during last year, and my time as finance portfolio holder. The question that I have is around the CHC income and the reliability of that. So the report makes clear that 1.654 million of the underspend is due to the higher than expected CHC income. So this is income that we're getting back from the NHS, isn't it? Continuing healthcare costs. This wasn't forecast during the year. It came in after retrospective reviews, effectively as a windfall. So that was nice. Windfalls can't be built into structural budgets. The question that I've got is, how confident are we in achieving that level of CHC income again in the next year? How are the CHC assumptions being built into the budget rebasing exercise? I think we might be straying into the next report as well. What contingency is in place if this level of CHC funding doesn't materialise, and when will the new CHC forecasting mechanism be operational?
Thank you. I'm going to give you a non-financial answer, if that's okay, Councillor Maldoni. So first of all, for clarity, what CHC is continuing healthcare. So that is somebody who, after going through what's called the decision support tool, which is it's got 9 domains to it, is determined that their needs are not adult social care needs, but their needs are primarily healthcare needs, therefore should be funded as fully funded through the NHS. Next bit to say. I'm going to give you a little bit of history on this very quickly, because it's important. It was in the past sometimes used nationally as a bit of a kind of a game between adults and between councils and the NHS And the accusation, quite fairly, not in Thurrock, by the way, but quite fairly, at the time when I worked in South West London, was I got really narked in working for a council when I saw NHS colleagues putting up a budget-saving target against CHC, yeah, which did happen. It doesn't here, quite rightly. What is happening, which is why I'm going to give you this answer, is I can tell you at the moment I'm relatively confident because the current activity is still demonstrating that we are achieving significant benefits on continuing healthcare. But we are monitoring it really closely because it's not a numbers game. This is about people and people getting the appropriate service. So whilst we've got the numbers of people coming through who we do a joint assessment of, and they meet the needs of they meet the criteria of the decision support tool fairly and transparently, we'll continue to meet the targets or the income stream, or overachieving the income stream, which was a significant factor in our underspend last year because we overachieved on it. And we're talking about human beings here, so I can't tell you, there's no pipeline. I can't tell you what the pipeline is going to be for the next, I can tell you for the next 3-4 months, it's looking fairly good. If in a year's time, 2 years' time, there are less people who are requiring a continuing healthcare assessment, then I can't guarantee this is something in 2 or 3 years' time that we're going to have, because it's based on demography and based on people's needs. So it's a very huge. I'm sorry to give you a slightly opaque answer. What I can tell you is it's looking okay at the moment. We're monitoring it really closely, but as far as a long term, I can't say because I don't know what the population, I don't know what the pipeline is going to look like as to whether we're going to have people coming through. I hope that's a reasonable answer.
I think that's a sensible answer, yes. And thank you for that. There are a number of other things, but I think if we look at, I think it's probably best to bring those up in the next one. I think the only other thing
Can I just come back on one thing? Sorry.
If I could just say this first, though. Again, this is a report with recommendations only to note. So I think we need to look again at how we bring the scrutiny element into this, because all the reports that do have recommendations have only got recommendations to note, and we need to look at what is the scrutiny element, what is the ask of scrutiny when we're looking at these reports. If they're just reports to note, I mean, really, what I'm saying at the moment is not, it's just we've noted the report. That's the only response to that recommendation. So
these reports have come from us from Cabinet, so they are as they are. So we can't. We can only note them at this point.
Okay, but I mean, we're commenting on them as we are. So, well, I've been commenting on them. And we're asking scrutiny questions. So I understand that it's not our decision to make, but there can be a scrutiny element put into the recommendations without there being decision making involved.
Okay, I'm told that has to be led by finance. Okay. Thank you. Councillor Spate.
Thank you, Chair. And just in the wake of what Sarah's just said, it's a concern I've expressed many, many times about the sanitisation of scrutiny, and the fact that we are asked to just note something that was told us how it's going to be. It makes scrutiny pretty pointless, really, because we need to have some teeth. But that's an aside to what I was going to say. I'm pretty thick, and I'm trying to look at this from the opinion of Howard and Hilda at 21 Acacia Avenue, who look at this figure, and I understand, I do know there is a complex situation, but the way it sits, to simplify it, is, we underspent significantly last year, 8% under budget, 4-point-something million, but yet we still went to the pot and the well and increased the adult salary and asked for a 2% rise in council tax specifically for adult social care. So we asked for that money, but actually when we delivered a set of accounts, how much did we actually need that 2%? And I get that the decision on what the council tax is going to go up by is made in the early part of the year when period quarter 4 is not yet completed. So it is a bit of a guessing game. But the public, I think, would say, let's hope that next year then, if you last year you ran on an underspend, and I know we're on an overspend on the item that we're going to come up to in a minute, but I just think, you know, how this looks to the public. We're underspending for whatever reason, and it's quite interesting that some of the underspend, where the underspend actually is on older people and disabled people, which is quite worrying. But you know, and I'm taking it to you, Val, as a cabinet member, when you are now sitting down, presumably, and preparing for next year's budget and next year's presentation, and I just ask, you know, to look at the public perception. If we delivered an underspend, why did we go and ask for more money from the well? It's simplifying it. And I do have a degree of sympathy because Dawn and her team came in and inherited a pig in a poke in terms of our financial reporting system. I mean, it was a mess, and I know we've now got a lot more people doing what we should be doing. So that may be the reason in its own right, that we just weren't very good at what we were doing. But bear in mind, if we do look as if we're going to have another underspend when we sat this time next year looking at these figures relative to sort of the current financial year, 25-26, that, you know, if it looks like we're going to have an underspend, then we don't go and take more money out of the household budget that goes into council tax. And that sounds really harsh, but everybody's counting the pennies these days.
No, and I understand that, and obviously it is very difficult to try and look in advance. You know, if we only had a magic sort of wand that would tell us, and obviously it does fund the preset, and some of this has been underspent, has been driven by salaries and some historic budgets that we say have been corrected, and the other part is that we've put some growth in for this, and obviously there wasn't as much growth. But if we look at where we currently are, this sort of the end of obviously period 1 coming up to the period quarter 2, it's much more in line with where we're expecting to be honest. So the preset that was put in for this quarter 1 and quarter 2 is much more in line than the previous year.
Yeah, I get that, Val, and I think you know, we are talking relatively large amounts of money, but in the scheme of things, they're actually quite small amounts of money. So it is difficult. But the idea of a budget at the end of the day is you cut square at the end of it, and some you're going to hit and some you're going to miss. I get that.
But you want to try and balance it.
I go back to, you know, if you know, in a world where everything was equal, if we had a year where we'd actually underspent and we had some money in the adult social care pot, instead of taking 2% and adding it on, we ought to be giving people a tax rebate. That would, you know, that's what, and it's incredibly simplistic, couldn't possibly work in practice. But as I say, Howard and Hilda, that's the way they think. And we need to talk to Howard and Hilda,
yeah, and
explain why we
given
do this.
a story that people can really understand. People that can understand and relate to. And I think, you know, one of the things that I have done since I've taken over being the portfolio holder, which I know that Sarah actually did start when she was the portfolio, is trying to make the reports much more simple, and so that, you know, we're trying to do these presentations so that people really do understand and can get into the grips of it. So if we all understand it and the councillors understand it, we've got a good chance of the residents getting to understand it. So we've still got a way to go in trying to simplify some things to make it easier for, as we say, you know, Howard and Hilda.
Yeah. Thank you, Val. I mean, it's just that we've all sort of got used now over the last 2 or 3 years since it came in that there's that 2% on for adult social care. And nobody's really going to argue against it because, you know, I'm there already, you know, but we're all getting older. and we all need care, and we all need a bit more attention and what have you. So we want to make sure it's there for us when we need it. So nobody's, I don't think, ever really gets uptight about paying adult social care, probably until you get to this point when you think, well, did we really have to pay it, actually? So let's just get better at, A, getting them figures right, which I applaud you on what you're driving down to do that, but also in terms of telling the story again. Yeah.
And obviously, you know, it does form part of the base budget as well that we do work for. And then we have to look, how do we add in growth? How do we add in the pressures that come?
Thank you very much. I think, are you able to move to the next report now, please?
Pardon?
Are you able to move to the next report?
Yes,
quarter one?
absolutely.
Thank you.
Oops, that's not it, that's it. So just back on what you were all talking about, that, and I do understand, because when I've been on scrutiny, I think there's nothing more frustrating than sitting there discussing a report and people talking about things and then just noting that it's there for note. And I do find it frustrating. Both of these have been to Cabinet previously, and obviously I've got quarter 2 coming out in December. It's something that I think, and I think actually, Councillor Spate, it was you, your fault over there. You started it by saying that you wanted finance to be discussed at every scrutiny, because I think prior to you asking that, I don't think it was something that was brought up at scrutiny. So, you know, I do understand. Let me try, I mean, it's not going to happen sort of in January because we've got the budget, but going forward, if we are in a position to try and work it where we can come to scrutiny maybe before we go to Cabinet, and you know, I'm not promising, but let's look at the timelines and how it works, because I think sometimes you've got a lot of value added to give, and you know, if it's already gone through and it's been approved by Cabinet, it's not been called in, you actually think, why are we actually bothering? So I do understand that. Let's look at what we can do, and I'm not promising it's going to work for everything. But I mean, you know, I'm coming up now to quarter 2 and I'm still discussing the outturn from last year and quarter 1, which does seem a little bit farcical to me. Right, if we go on to the outturn for quarter 1 update. So the service is currently forecasting a balanced budget. You'll be pleased to hear, Councillor Spate. There was actually the 2.896, not 2.7 pressure, but it has been covered by the Better Care Fund, as I did speak. And the funding has been agreed from the Integrated Care Board, and that's been done. The assumptions are that we did put 3.2 million in for growth, and it was set aside for things like population changes, inflation. Instead, what we're trying to do now with that growth, we're holding the growth centrally and then just seeing, as we said, when we're looking at the end of each period, where the pressures are. And I do know that there are pressures coming in social services with adult placements. We are looking at possibly a £500,000 overspend there because of the commissioning of how we commission placements. So I know that the team are working very hard at how can we look at things differently, and it may be by the block purchase of properties, not properties, of beds, rather than just doing it piecemeal, because we are getting challenged by, whereas we are quite good value for money, and a lot of people from outside are looking and seeing that they can procure here because it's probably better value than where they are in their own authorities. So it is something that we are looking at and looking how can we do that better in the future. If we look at where we are with the savings, and you know, if I was in your place, I would turn around and say, goodness me, you know, you're saving that nothing has actually been delivered in quarter 1. I can give you some real assurance that by quarter 2, a large proportion of this has now been delivered. A lot of it was timing, but it doesn't show well when you're looking, my goodness, you want to save like 5.7 million and you're saying that nothing had been achieved up to quarter 1. And that the pressures now is down to £40,000 as seriously at risk, where some things have moved around. So that is quite a good news story and testament, I think, to the team where, you know, you've all said it, several times that they really do have a can-do attitude, and how can we, and not sit there, how can't we? I think because I'm trying to race through this, I have got pages that I could have spoken. I'm very mindful of the time, and I know that you still have your forward programme to do. So I'm happy just to take some questions, and, you know, we can send these slides out to each of you. Anybody else has any further questions, please just ping them through, and I'm happy to take them.
For your report and your work again. I know, I'm just talking. So I would just like to make a few comments. Obviously, we do have, we were talking about fluctuations earlier, and I think one example is that there was a underspend on external placements at the end of last year, and there's been an overspend.
Now we've got a pressure.
So that just goes to show the moving, you know, the moving scheme of that. On the tracker, it's interesting to note that a lot of the at-risk things are featuring down to staffing and recruitment issues that we touched on earlier as well. So that's just where it all sort of ties in, the finance and the actual down on the floor working as well. So that was interesting to see. Another thing that would be interesting for me would be a breakdown of the public health spend. Because we haven't got any breakdown on that, and particularly with all the, you know, inequalities.
That's going in the Q2 report.
Oh, is it? Lovely, thank you. And as we do have such an issue with inequality, if there are reserves on the Adult Social Care Fund, is there any way that, because there is a link between public health and everything, is there any way that some of those funds can be moved across for projects that public health might want to do, for example?
Providing they do a solid business case that stacks up, yes.
Yeah, thank you for that. As you know, I'm new into the post, so I'm reviewing the public health grant as well as the broader aspects of public health. The public health grant is governed by a number of nationally set terms and conditions, and any use of that grant obviously has to comply with those terms and conditions. But as you know, public health, we've talked through today how many factors influence health, and they're really broad. And we work across the council, and we'll continue to do so with other departments, closely with adults and children's, as well as we talked a bit earlier with the regulatory services to improve public health outcomes.
Thank you. I know Councillor Spake wants to ask a question, but would anyone else who hasn't asked many questions this evening like to ask a question first, just that time is tight? Is anyone that hasn't asked anything like to ask at this point? No? Okay. In that case, Councillor.
Yeah, I sympathise with you, Chair, and this new regime of you shall hit the clock compromises what we do. But there you go, that's a discussion for another day. Two things, I'll try and keep them as quick as I can, and they are related. We spoke earlier about the 10-year plan and the commitment to try and drive people, drive's the wrong word, but take people out of acute care in hospitals into care in the community. And Rob sort of alluded to it earlier on about when they're in hospital, they're usually getting paid for by the NHS. Once they come out, they're getting paid for by us. So how close, and you're going to tell me very close, I know you are, but can you give me the comfort and assurance that we really are looking at that? Because I'm assuming that the ICB or the Mid and South East, they're now trying to get people out of hospitals onto us, which is going to up our bill. So presumably we have really close dialogue with that. And I'll chuck the second question in. Given that these people are then coming into our community and needing care in the community in various homes, I have had it raised with me previously, and this is one area where maybe there's a bit of criticism about the innovation, which I normally laud in your department. There's a guy who operates a couple of care homes in the borough, and he's lamented the fact that he's struggled to have real dialogue in terms of how he can work with the council to provide care on a cheaper level. And you know, he may well be spinning me a different story to what reality is. You know, not everything we're told is true. But there was a definite concern, and it just brings to mind, would it be a good idea, knowing that we're going to get more people coming in, to, and I draw the comparison with housing, where you held a seminar and invited people who built modular homes to come and present what they do, how they do it, what would be good for Thurrock, what wouldn't be good for Thurrock. Could we not go and invite the care sector, and you're going to tell me, I know, because I can see you smiling that you're already doing this, but get them in and have a similar sort of say and say, look, forward planning, you're developing your business, you're planning what you're going to do, let's talk here and now what we can do to mutually scratch each other's back. And I'll leave it there.
So yes, we are smiling because I mentioned earlier on about the supported accommodation strategy, and actually I've been speaking with commissioners. That's one of the things we are looking to do. So we're looking to run kind of some sessions where we will talk to, we'll be clear about what kind of provision we think we need in the borough looking forward, and then talking to developers about doing that. We've got a group that meets with the planning department, with the regeneration department, and with NHS colleagues. So,
sorry, I don't know whether I made that clear. I'm not actually talking about housing developers. I'm talking about care home operators. I mean,
yeah, well, so
Christian,
we can engage with,
yeah.
so that's a slightly different question, and we can engage with them as to what we think the models might be in the future and see whether they want to play in that space. So we can explore that. The first question you asked, I'm going to give you a very non-financial, I know you made the question to our finance lead member and an accountant in the room, but I'm going to risk not giving you a financial answer, which is fundamentally the person's needs should be the driver for where they get their care, and who pays for it, not a financial driver for us to keep somebody in hospital longer because the NHS is paying, or the NHS wanted to discharge somebody quickly because it comes to local authority. That is the wrong way to do it. So we are absolutely transparent in our relationships, and I think the relationships we have here are much more mature than where we worked previously. I'm telling you, I think that we do that quite well. So the money follows the person's needs, not the person being driven by us trying to save money by keeping them out of hospital. Okay.
Councillor Muldowney.
Thank you, Chair. Yes, obviously our new corporate plan sets out as its very first deliverable a commitment to improve our financial management and internal controls. So if we take that seriously, I think Councillor Morris-Cook is right to say that the Q1 report must ring some alarm bells. In section 4.1, we see the 2.896 million overspend being fully funded by a planned drawdown from the Better Care Fund Reserve, and this is at Q1. That's not an in-year contingency, that's a financial strategy from the outset. So last year, I think we insisted that services come in within their budget envelopes, and directors were held accountable for controlling costs, and reserves were only used as a last resort. And that discipline helped us to deliver, an overall balanced budget at year end. You'll have to forgive me if I've got this wrong, but it seems this year the approach is reversed. So section 4.2 shows that the 3.203 million of growth funding is being held centrally on the assumption that the BCF reserves and last year's underspend will cover rising demand. That seems like a material strategic shift from fiscal discipline to reserves dependency, so that's my first area of concern. At the same time, section 4.4 shows a 3.822 million overspend in external placements, mainly for older people, mental health and physical disabilities. Mental health direct payments are averaging £1,066 per week, which seems exceptionally high, and I'd like an explanation of that and some benchmarking. I tried to do a little bit of benchmarking. It's a bit difficult because it isn't apples for apples, but there was a report by Personal Social Care Research Unit which shows that their weekly revenue cost estimate was around 720 per week. As I say, you can't take this, it's not exactly apples for apples. Other councils have mentioned that their unit costs are 932 per week. So I think this is the kind of area where, as a scrutiny committee, we could really add some value, doing a deep dive into why that is. I mean, it could be that it just happens that the complexity of needs of our patients and the people that we're serving, of our residents, is just a lot higher, and that is what's adding to the cost. But I think, you know, that definitely needs looking at if we're going to make sure that we reach year end without running out of reserves. Section 3.6 shows 40% of savings at risks. I appreciate that Councillor Maurice Cook has reassured us that the Q2 figures are looking much better. Section 3.3 bakes in a 0.95 million rebase based on last year's underspend, but without published evidence to show that it's genuinely recurrent. So that, how confident are we basically that that underspend is going to recur again? And the risk register in Section 8 is still largely green, which doesn't seem to reflect the scale of the problem. So, if I were to ask that in questions, I'd want to know, why is the financial strategy, you know, first of all, it looks that way to me, but why has the financial strategy shifted from containing spend to early reserve drawdown? Is that political direction from the portfolio holder, or a decision taken by senior officers, or a decision taken together? Or am I incorrect about that? What's the exit plan for the Better Care Fund reserves, and how much resilience will remain by Q3? That's my concern. Where is the evidence supporting the 0.950 million rebase? And what triggers will actually release the 3.2 million growth funding, which, as you said, is being held centrally? And when will members be told? And why does the risk register not seem to match the scale of the pressures? I'm not going to talk about reports to note again.
Thank you, Councillor Mulder.
So I will try and do that very quickly, because I know that I've probably got 3 minutes.
Yes, I was going to say...
So the ICB had a report that was sent to them that they approved the use of the Better Care Fund to cover the placements. The rebasing is something that we are moving to go through. We will have a better position by December, where we have the Q2 outturn, and we are holding the growth centrally, because it's a more sensible strategy to see where the pressures are and where they're going to be delivered to.
Risk register?
I'm aligned with the risk register.
Okay, so it's okay that it's mostly green. I don't know, it just doesn't seem to reflect the actual risk position at Q1.
Because Q1 is very early on in the stage, we are seeing what's coming through on a monthly basis. I do believe that I think the risk register is correct as at this moment in time. We know that there was some growth there, that we could be covered of any potential overspends. The teams are mitigating what the demands are that are coming through to them. Where I looked previously, where we were with savings, where we went from the savings to the mitigation, I do believe that that should have probably been amber at the time, but because they mitigated and went to 40,000 as that wasn't going to be delivered, that should be green now, because that can be mitigated within the service going forward.
Thank you.
Thank you.
And presumably we'll know more at Q2 about the other items. Thank you.
Thank you. Sorry to rush you there, Councillor Maurice Cook. Thank you very much for your your reports tonight, and also for your offering of going back to look at Cabinet and scrutiny. That's great, thank you. May I ask members if they're okay to extend for 10 minutes for us to finish the remaining items on the agenda quickly? Is that agreed with everyone? Okay, we'll carry up. We'll go through briefly the rest of the agenda. So item 9 is the work programme, which can be seen on pages 93 to 96. Briefly for tonight, the Health Watch discharge report was due to come, and that's been deferred. We're not sure yet when we're going to put that in. We are waiting to see if we will have an extraordinary meeting. We haven't had that confirmed one way or yet, so we will update you with that. I don't know if any members have any comments on the work programme. Okay. So then we will look at the... Oh, sorry.
I know we've got the ICB in January. What about the Hospitals Trust and the significant changes in things that have happened there?
So in January we've got the ICB, which will be an update on that. We've also got them covering the changes in mental health and the GP services update. That's in January. In February we've got the NHS 10-year plan, which is going to also have a focus on A&E and cancer. And then if we do have an extraordinary meeting, that will focus on the latest sort of CQC ratings and the league table. That's what we're hoping for, but we've put in a request and we're waiting to see if that's going to go ahead, so we will update you.
I was aware of that, and I was sort of expecting there'd be some mention of that there. I mean, we really do, on behalf of our residents, we really do need to ask the very difficult questions. At our last meeting, we had Tom Abel and Nigel, I believe it was, who apologised and said how embarrassed he was about how bad, and he must have known then what was still going to come through the door. So, you know, we've really got to keep our foot on their necks, if you like. We really, really have to.
Councillor Spate, can I just come in there actually to say that we have had an update on the Orsett Hospital situation. They are going to have a working group to look at a plan for Orsett. We're just waiting on the terms of reference, and we will come back with more detail, but it is being worked on. So just to update you on that, as you've mentioned it there. We've next got the action log, which is on pages 97. So I think some of the things you've just raised there, Councillor Spate, are on there. I don't know if anyone's got any comments on anything on the action log there. Yeah.
Thank you, Chair. I just wanted to say that some of the actions remain open as they relate to topics that will be included within reports later in the municipal year. And also for action point 2, just to say, obviously, Councillor Rigby, that you attended that meeting. So I have made a note of that as well, so we'll include that.
Thank you. And there is another meeting in the next sort of 10 days for that as well. Oh. And then we've got the recommendations tracker as item 11. So is that, have we done that one? You want to come on to that one, Claire?
Yes, it's just for information purposes. It complements the minutes and the action log to highlight the scrutiny's journey of the reports and includes the briefing notes that have been supplied to the committee as well.
Yes, thank you. So the NHS Health Check programme we did circulate, and the update on maternity services was also updated. I think there was something that was due to go to Cabinet in November, equipment procurement, that's been postponed till next year. I might just quickly, if actually Kim couldn't come tonight, she was going to give a quick update on Health Watch, but as far as I'm aware, they have got secured funding now, haven't they, from April, and we'll hopefully learn more about that at the next time she comes. But that was something we did also bring up at the last meeting as well. So I think, unless anyone's got any comments, I think we've got a couple of minutes within our 10 minutes if there is anything. Okay. Yeah, no, I think that's great then. Well, thank you everyone for coming this evening and for your contributions. And I shall now close the meeting at 21:34. Thank you.